안녕하십니까.
Hello, Dr. Steve Easy Hands-On. I'm Dr. Kim Kyung-won. Today, I'm going to talk about the CAS kit. The CAS kit, I believe many people already have used it and have experienced the kit. It stands for Crystal Approach Sinus Kit. Its main characteristic is to safely and easily hydraulically elevate the maxillary sinus membrane without damage or perforation of the sinus membrane, to place implants at the maxillary posterior region using the crystal approach and do the bone grafting. Let's look at the characteristics of the CAS kit. First, CAS drill itself, the top of the drill has the inverted cone shape and the edge is rounded. So when you use the CAS drill, it doesn't cause or minimize the damage or perforation. You can penetrate into the sinus floor. There's a stopper so that you can drill to the depth that you want. Secondly, hydraulic pressure is used to safely and easily elevate the sinus membrane. The hydraulic pressure tool is included. Third, bone carrier and condenser can be used. Crystal approach can be used for the bone grafting in the sinus. Bone graft can be prevented from being contaminated from saliva and others, so secondary infection is prevented. Bone graft can be easily done over the sinus floor using the bone carrier and the condenser. Components of the CAS kit. Basically, there's a drilling tools in the CAS drill. Second, after penetrating into the sinus floor, sinus membrane can be easily elevated, hydraulically elevated using the tool, and the bone carrier and condensers are in the bone graft tool. 3 types of tools are available. First, the guided drill. Basically, it is to mark the drilling location. Basically, 2 mm stopper is recommended to do the marking. The recommended RPM is 1000 to 1500 RPM. The length is the same as the CAS drill. Next, the twist drill. After the initial drilling, before using the CAS drill, this can be used. In the case of the twist drill, on the panorama or CT, after evaluating the residual alveolar bone height at the maxillary posterior region, you need to underdrill by 1 millimeter less than the height to be safe. Its specification is the same as the CAS drill, and the stopper can be used to adjust the length of the drill. CAS drill, basically it is designed to penetrate into the sinus floor, maxillary sinus floor. As I said before, its edge is rounded and has very good cutting efficiency or power. So, without damaging the sinus membrane, you can penetrate into the sinus floor. That's how it is designed. At the top, it has the inverted cone shape of a bone lid, which is designed to minimize the damage to the membrane. Next, if it is drilled at a low speed, the side of the straight drill is designed to collect the autogenous bone chips. The recommended RPM is around 800. Then you'll be able to drill easily without problems. There are a short one and a long one. The diameters of the drill is 2.8, 3.3, 3.8 for soft bone, and 3.1, 3.6, and 4.1 for normal bone. The stopper is very important when it comes to the CAS drill. To lift the sinus membrane, when you attempt to penetrate into the sinus floor, this is used to control the depth of the drilling. The stoppers are 2 to 12 millimeters in 1 millimeter increments in the specification. There's 2 here, and you can see 2, 3, 4. It's marked like that. When you connect the stopper, the CAS drill's protruded drill length is indicated there, and they are color-coded and laser-marked, so you can easily do the drilling in the depth that you want using the stopper. Next, the depth gauge. As I said before, the same length stopper used for the CAS drill is connected here, then 0.6 millimeter more protruded. After the drilling, this can be used to check whether the sinus floor is penetrated or the membrane is damaged using the tactile sensation. So the stoppers can be connected here as well. Next, hydraulic membrane lifter. Simply put, after penetrating into the sinus floor, hydraulically, the sinus membrane can be safely lifted. For this hydraulic membrane lifter, 3 cc syringe is recommended. The pressure is not high. The sinus membrane damage is minimized when lifting. In general, normal cell line is infused, but not infused all at once. The silicone part should be adapted to the drill hole so the cell line is not leaked. First, you need to infuse 0.5 cc and aspirate. The blood inside can be suctioned out. If there's no membrane damage, you will be able to feel the negative pressure. With a crystal approach, it's basically a blind approach, a conventional oscillotome. When you use it, we cannot accurately detect the tearing of the membrane. Using the Valsalva maneuver, you can check and stop the procedure, but if there is minor damage, you will not be able to feel the tearing. But if you do like this, 0.5 cc is infused and then it's aspirated, you will be able to feel the negative pressure. Whether there is a membrane tearing or not can also be detected that way. After that, 1 cc is infused and aspirated, followed by 1.5 cc infusion, etc. If you lift the sinus membrane this way, the wider base sinus membrane can be lifted. After the bone graft, the bone formation can be made on a wider host bone base. Next, the bone carrier. It is shaped like a funnel. 3.1 drill hole uses the 3.0 carrier. 0.1 millimeter is shorter in diameter. So graft material can be put into the funnel shape safely, and it is hydrated and pushed up. The tip length is shortened. In the past, the tip was longer. When you push it into the sinus membrane, sometimes membrane was damaged, so the design is changed recently. Next, the bone condenser. Bone material is put into the bone carrier and hydrated. There are 2 diameters for the bone condenser, 1.1 and 2.0. 1.1 is used when bone graft material is blocked. So that is to prevent that, to push it up continuously. Diameter 2.0 is used to lift up more bone materials. Next, bone spreader. This is an optional tool. When you do the implant placement, the graft material is blocked and stopped being pushed in, then bone spreader can be used to spread the blocked bone material. There's a recommended sequence for the casket surgical procedure. I will try to explain it in an easy way so that you can understand better. There are basically 3 sequences of drilling in our recommendation, and I will use some diagrams to explain it. The first method, before we penetrate into the sinus floor, CAS drill diameters are increased step by step. And the last one, fitting the fixture diameter, the thickest diameter drill is used to penetrate into the sinus floor. To minimize the sinus membrane damage, thicker CAS drill would be used to penetrate into the sinus floor without damaging the sinus membrane. First guide drill, then twist drill 5 millimeters, 3.1 CAS drill, and then 3.6 CAS drill, 5 millimeter stoppers. So stoppers are changed to advance into the sinus floor. In the diagram, as I said before, if the residual bone height is 6 millimeters in normal bone, with the 2 millimeter stopper, the guide drill is used. Still 5 millimeter high bone remains. Using a twist drill, we go up to 5 millimeters. CAS drill is used 3.1 and 3.6, using the same 5 millimeter stoppers. Then 3.6 is used to advance into 6 and 7 millimeters. Sinus floor can be penetrated into without damaging the membrane using the hydraulic elevation. The second method, the CAS drill length is increased until penetration into the sinus floor. CAS drills are used to penetrate the sinus floor, followed by the hydraulic membrane elevation, and the final drill is used to do the widening. The same example, 6 millimeter high normal residual bone, guide drill 2.2, 3.1 drills, and 5, 6, 7 millimeters. That is, the diameters increase until the sinus floor is penetrated. After confirming the penetration, hydraulic lift is done, and using the final drill fitting the diameter of the implant to be placed, the drill hole is widened in this method too. Next, method 3. This is the combination of method 1 and 2, previously explained. The CAS drill's diameters are increased. At the same time, the lengths are increased as well to easily penetrate into the sinus floor. The drilling sequence is reduced. In this way, if you get used to the CAS drilling, you will be able to do it easier. The drilling sequence can be greatly reduced or simplified. Like this, at the beginning, 2 millimeter stopper is used for the guide drill, 5 millimeter, 2.2 twist drilling. After that, CAS drill 3.1 with 6 millimeter stopper, 3.6 wider diameter, and the longer length is used. Then drilling sequence is simplified, followed by the hydraulic elevation of the membrane. Out of method 1, 2, and 3, you can choose whatever fits you, whatever is convenient for you. If you get used to using CAS drills, you prefer to use the method 3 because it has the simplified sequence. Next, easy hands-on. The objectives of the easy hands-on. On the model, cascade will be used. Through the crystal approach, sinus lift will be made. Bone materials will be inserted to place an implant. Using the cascade, sinus flow will be penetrated. The main function of the cascade, the hydraulic membrane elevation will be done safely, and bone grafting followed by implant placement in this hands-on. In this model, number 25, 26, 2 teeth are missing. As I explained, cascade drills will be used to penetrate into the sinus floor. After that, hydraulic elevation tool will be used to safely lift the sinus membrane. After that, bone carrier and condenser will be used for the bone grafting, and the fixture will be installed. Through this hands-on, you will be able to see this process. I'll come back to the hands-on. Thank you. Cascade hands-on. In this practice, 25-26, 2 teeth are missing at 25. The residual alveolar bone height is 5, and at 26 it's 4 millimeters. But the alveolar bone is slightly sloped near the adjacent teeth. Therefore, we need to go deeper to penetrate into the sinus floor. Now let's start the hands-on. The initial drill, guide drill 2.0 is chosen and is connected to the handpiece. For the guide drill, we need to check the location. 2 millimeter stopper is connected to identify the placement location. Now it is connected. The guide drill tip is protruded a little bit. So it is marked black on the white model. At 25 location, the marking is to be made. And number 25, on the X-ray, the residual bone height is 5 millimeters, so twist drill is chosen. The remaining bone height is 5 millimeters, so 1 millimeter under drilling is to be done. So 4 millimeter stopper is used. (2.2) twist drill. At 25, 4.5 millimeter fixture will be installed. CAS drill, diameter 3.1 is chosen. 3.1. Using the method 3 that I explained, 1 millimeter advance will be made. 5 millimeter stopper is connected. So 5 millimeter stopper is used. The residual bone height is 5 millimeters. 5 millimeter stopper is connected to the CAS drill. So the sinus floor will be penetrated or not will be checked. So depth gauge will be connected with the same stopper. In the depth gauge, the same stopper is connected. 5 millimeter stopper. The drill is 5 millimeters, but the depth gauge is a little bit longer, 5.6 millimeters. And this will be going into the drill hole to check whether sinus floor is penetrated or not. As you can see, it is not penetrated yet. Next, 4.5 fixture will be installed. So the CAS drill diameter 3.6 is used. 6 millimeter stopper is connected. Because the sinus floor was not penetrated with the 5 millimeter stopper, the drill hole is not opened yet, so depth gauge is connected with the 6 millimeter stopper to check whether the sinus floor is penetrated. The residual bone height is 5 millimeters, but there's a slope near the adjacent tooth. Therefore, we need to go a little bit deeper than we expected. The final drill is 3.6. The drill diameter is not to be increased. The stopper, 7 millimeter stopper, is used for the drilling. Seven millimeter stopper. Now I feel it is being penetrated. 7 milli stopper is connected to the depth gauge. When it is connected, 7.6 millimeter protruded portion is observed. The sinus floor is not yet penetrated. We thought it would be 5 millimeters. We use up to 8 millimeter stopper because sinus floor is sloped and the alveolar bone itself is also sloped. So 8 millimeter stopper is used. Now it is drilled. Once again, 8 millimeter stopper is connected to the depth gauge to check. As you can see, partial penetration is confirmed. Now hydraulic elevation will be done. Partial penetration is done on the slope and the hydraulic elevation is to be done. Hydraulic lifter is removed and connected to the silicone tube. Next, cell line will be infused. A lot of air in the tube is not very good. So 3 cc syringe will contain enough cell line and it is connected like this. Then if you see here, there's air inside. Cell line is infused to remove the air and it is sucked out. The 3 cc syringe is filled with up to 2.5 cc cell line. Using a needle holder, the hydraulic lifter is adapted to the drill hole. 2 millimeters is slowly infused and aspirated. like this. 0.5 is infused. So this way, hydraulic elevation is being done. How the sinus membrane is lifted will be observed by looking at the inside of the model. Like this, it is being lifted. Slowly, it works. The sinus membrane is being elevated. Hydraulic elevation is finished. Now it's turn to do the bone grafting. The final drill was 3.6. This bone carrier is inserted into the hole, and from the back we can adjust the angle into the bone carrier. The graft material is inserted. Sufficient bone graft material is inserted using the bone condenser. This is pushed in. 1.1 millimeter diameter is used. Then no blockage will be made. 2.0 diameter condenser is used to insert more quantity of the material without encountering the blockage. Using the bone condenser, the graft materials are inserted. If internal bleeding occurs, the bone materials would be dispersed. So you use the hydraulic elevator and aspirate, and then the bone materials would come down. Next, implant is to be placed using the mount driver. 4.5 diameter by 10 millimeter long fixture is to be placed. So the mode of operation should be checked whether it is fixture installation mode. So the torque is high. Using the hand wrench, positioning will be done. Using the hand wrench, it is fully seated. 30 Newton centimeters, enough torque has been achieved on the model. This is the TS fixture, and it will be placed up to 1 millimeter below the bottom of the bone level. 2 implants will be placed. And for hydraulic lift, if we make 2 holes together, water leak can occur. So it is inserted before number 26 drilling is done. 2.0 drill, the guide drill, will mark the placement location. 2 millimeter stopper is inserted, connected. The drill is made. At 26, the residual bone height is 4 millimeters. 2.2 twist drill will use 3 millimeter stopper 1 millimeter less than the height of the residual bone. Drill hole is made. CAS drill 3.1 diameter CAS drill and 4 millimeter stopper is connected to advance 1 millimeter. (3.1) and 4 millimeter stopper. (4 millimeter drilling is done, and the depth gauge is connected with the 4 millimeter stopper to check whether the sinus floor is penetrated. It's not penetrated yet. Next, 5.0 will be done, but first 3.6 CAS drill and 5.0 millimeter stopper is connected. CAS drill is increased by 1 millimeter in diameter and in the length as well. Using the CAS drill, now 5 millimeter stopper is connected to the depth gauge to check whether the sinus floor is penetrated. Part of it is penetrated. It's not completely penetrated. So let's advance a little bit more. 5.0 fixture is to be installed, so 4.1 CAS drill is to be used with the 6 millimeter stopper for the drilling. Now I can feel it is penetrated. Now it is connected to the depth gauge. The sinus floor, part of it is penetrated, so hydraulic lifter is to be used again, and it is adapted to the hole. Two millimeter saline is in the syringe. Infused and aspirated. Infused and aspirated. Hydraulic lift is being done. Now it is lifted. Let's have a look at how it is lifted by removing this model. The mesial fixture is placed. When you do the hydraulic lift, you can see the membrane is being lifted. Aspiration. Negative pressure is formed, so it doesn't move anymore. We will do the bone grafting again and place the implant. Bone material is inserted and it is pushed in with the bone condenser. Due to the hydraulic lift, the water is coming out. In this case, as I explained, hydraulic lifter is connected and aspiration is done. The water and bone materials are coming down. Due to negative pressure, it cannot be suctioned very freely. Perforation is not made, as you can see here. Now, 5.0 by 10 millimeter fixture is placed. The bone is very hard because it's a model. Now implant will be placed on the final stage with the wrench. The stability is good enough. 1 millimeter under drilled. The fixture is placed. Relation with the opposing teeth, they are properly placed as we wanted. Let's have a look at the inside of the sinus by removing this. This is the model. As you can see, bone materials entered into the sinus. Sinus membrane is lifted. As you can see in the sinus model, here the pre-mount is to be removed using the open wrench. The stability is good enough, so it doesn't matter, but I'm using the open wrench to hold it. 1.2 driver is used to remove the mount. Next, it is removed by hand. During surgery, healing or cover screw can be used. TS3 implants are placed deep enough, 1 millimeter below the inferior bone level. Now the surgery is finished. Doctor's tip, easy hands-on. I've introduced casket. I believe you already have used it a lot, and many doctors know about casket, but through the hands-on, as I showed you, if you understand the casket properly, regardless of the residual bone height, in various cases, you will be able to do the bone augmentation on the sinus floor to place implants. I believe if you are skilled in using casket, it will be very helpful in placing implants properly. Thank you. Q&A session. Let's look at some of the questions we received. Dr. Park asked, when we do the surgery with the casket, how can we check the sinus membrane perforation? As I explained before, when we do the casket surgery, hydraulic lift is done. When membrane is perforated, 3 cc syringe is used to push in 0.5 cc, followed by aspiration. If the sinus membrane is perforated, the air in the sinus comes into the syringe, creating air bubbles. Negative pressure is not formed. So, crystal approach is a blind method. When you use conventional Osstem, and if you feel the sinus membrane is perforated, you can stop the procedure, then it's okay. But the problem is when the membrane is actually perforated, but you proceed with the procedure thinking it is not perforated based on the Valsalva maneuver or other techniques. If you can use the casket and the membrane is perforated, use the hydraulic lift to infuse the cell line and aspirate. Air will come into the syringe and negative pressure is not formed, even though you cannot see. Indirectly, you can tell for sure if the sinus membrane is perforated or not. So during the surgery, if you can tell for sure the sinus membrane is perforated, bone grafting should stop. That means short implants can be placed, or lateral approach forming a window can be used to see the perforation directly with your eyes and do some repair and continue with the surgery. If you cannot do the lateral approach, you should stop the surgery and you need to wait 3 or 4 months to try it again. I don't know whether that answers your question. The next question. What is the minimum height of residual bone in the upper posterior to do surgery with a CAS kit? In the past, we determined the lateral versus crestal approach depending upon the height of the residual bone of 5 millimeters. If the residual bone is higher than 5 millimeters, crestal approach. If it is lower than that, lateral approach. But recently, as CAS kit is widely used, even when the height of residual bone is 2 or 3 millimeters, crestal approach is used. So in my opinion, rather than the height of the residual bone, the implant's primary stability, that means the initial torque, whether it is enough or not, is important. Even though the height of residual bone is 2 or 3 millimeters, crestal approach is allowed. Personally, I believe the age of the patient, whether the patient is very old or there's a denture in the opposing teeth, or in the most posterior region, a tooth like number 7 is there distally, these need to be considered. The height of residual bone can be low for the crestal approach. If the patient is young and it is free-ended distally and the opposing teeth are healthy, we need to have a long-term perspective. We need to do the bone augmentation. If the residual bone is low, lateral approach can be used for the bone augmentation. Therefore, the height of residual bone cannot be the absolute criteria for lateral or crestal approaches. Various factors need to be considered to make the decision. Next question. During the casket surgery, how can we repair the perforated membrane in the sinus? I touched upon this in the first question. During the casket surgery with hydraulic lift, if you can tell there is definitely perforation in the sinus membrane, you should not just push ahead with the surgery. There can be a risk of infection. For the perforated membrane, you need to change the approach to lateral approach to check and observe the perforation of the membrane. I repair using the tissue glue like fibrin glue, and the repair should be done and proceed with the surgery. If you cannot do the lateral approach, you can place the short implants after the bone grafting or wait 3 or 4 months to try it again. Due to constraint of time, I'll conclude here. If you have further questions, please send that to us. We will try to address them to the best of our ability. This concludes the CAS kit Easy Hands-On. Thank you.